welcome. And I would like to thank all of the panelists. My name is Angel Rodriguez. I work in clinical management in the ER for the unit of infectious diseases. And along with me, we have Milena Corredor and Priscilla Born as well. She is a virologist and she has a zoonotic influence. She's part of this team. And as you can see, we have Dr. Valeska Stempliuk. She is an advisor on transmittable diseases for PAHO Ecuador, and she's a specialist on control of infection, as you may all know. She's going to help us with this topic that actually we have been implementing for several years in the region. And I would like to thank our colleagues from Costa Rica. We have Edward Siles Saraya. He works from the Costa Rica unit on implementations and experiences. And he has been working as a regional supervisor. We have Carol Brenes from the she has been working for 6 years in this area. And we're gonna have a video, from Ms. Ospino, and unfortunately, we're gonna see a video because unfortunately the presenter cannot be here. And as you can see, you have the agenda there. This is the first item in the agenda, and then we're gonna start with the presentation on respiratory protection program. Why is this important? Well, this is part of the efforts of preparations, and it would be this is important. And in the face of answering the emergencies. And I would like to highlight the commitment of organizations, particularly preparation and response. And we hope that this could be of use, and you could type in your questions and your answers. And we have an experience as a region, and I think that it will be of use for you. Valeska, you can go ahead once again. Here, and particularly on our day-to-day, we would like to protect the workers and the patients, and the content it will be based on the guidelines that PAHO have introduced in English, Spanish, Portuguese, related to this topic. And now I am going to switch to Portuguese. I understood that I should be speaking in Portuguese, so I'm going to switch to Portuguese.
Problem. There are three aspects that are fundamental that we all know, workers, we know as professionals, and we need to consider. First of all, we need to acknowledge the problem. Dr. Rodriguez already talked about that, the problem that we have in terms of the emergency situations. as the COVID-19, but there are also daily situations because we have patients in our hospitals that arrive with diseases that are transmitted, airborne diseases, and and we also have the health workers. We need to know the risk, we need to know the dangers we have in our health services and the control measures that are available to minimize those risks. And finally, what's a program of respiratory protection? Most countries in the region are just starting developing these programs. We are going to be able to know the experience of Costa Rica, how it was implemented, but they are essential. Although they were disregarded for a long time in our region. First of all, I wanted to bring to the table a problem we have. We know this problem, but this is just to start the discussion. Here, I bring data, the global report on tuberculosis, and this graph shows that tuberculosis is a disease, an endemic disease in our countries. We know very well, we know how to diagnose it, but it is transmitted in our health services. This is maybe the best example we have of a disease that is putting the risk of our professionals at risk. This graph shows in what countries, and here we see the region of Americas, in what countries the health professionals are at more risk of getting tuberculosis. And this is related to the activities they do daily. People are getting infected in the health services with respiratory diseases that could be addressed with respiratory programs. What's increasing this problem is that most of time, and we are going to be able to discuss about it, we think we are protected because we are using the K95 mask or other types of respiratory devices, but we are not using very well the devices we have because we don't have people who use the mask in the proper way because of different factors that contribute to the bad use of the resource and that is not contributing to the protection, although people think they are protected against the risk. The respiratory diseases. What are the risks that we have in the health services? We have many risks. Most of us, when we want to control infections, we always have a gap, but there are always other risks that we need to consider: bacteria, viruses, fungus, chemical materials that also have a risk against the respiratory tract of our professionals, and other ergonomic risks that are not directly related to respiratory diseases, but they are present and they need to be considered. There are some respiratory infections related to other risks that are not biological risk, as we can see here, and they are due to the continuous exposure to agents that are causing these disease problems. And there are also many diseases that we have in the hospital to treat these diseases, and we need to protect our health professionals. We have anthrax, we have aspergillosis, we have chicken pox in many patients. We have this in many countries in the region, and especially also outbreaks in the health services. We also had recently the monkeypox. We have SARS, COVID SARS-CoV-2, our recent friend from the pandemic. We also have smallpox. We have other emergency pathogens, and we need to be prepared to respond. We have these emerging pathogens and other diseases for which public health guidelines recommend isolation from airborne infection. We also have influenza, tuberculosis, SARS, COVID-19, measles, that are always recurrent in our health services. We need to be prepared to face all these risks. We all know that all infectious diseases are usually transmitted in the same way. We have a host that is usually a patient, a reservoir. This reservoir, this agent, is going to leave the reservoir, is going to be transmitted through many transmission routes. And the discussion today, we are going to see how we can protect the respiratory ways. And we have a source that is infected or colonized by an infectious agent. This red bar is referring to the protection ways that we have to prevent infection to get to the patient. And to protect this, we need to know the risk. We need a risk assessment to protect the professionals, or what we are discussing today, respiratory protection. In general, in our hospitals, when we have a risk assessment, we have three large sources or reservoirs. One that I already mentioned, patients with natural transmission, an infection, a new infection as SARS-CoV-2, or an infection, a new unknown infection as measles or tuberculosis. Other exposition source and that we should also consider is the exposure to toxic gases or vapors, mainly in laboratories, in clinical analysis laboratories, but also in the area of endoscopy or sterilization. This is an area that I invite you to know, to work more in this area, because our professionals are being exposed to different events here. And also when we have also an exposure to different types of dust or fibers in the case of construction sites. They can be toxic dust or toxic fibers, or sometimes with content of fungus that can also affect the respiratory ways. Most of the time, we can assess the risk by using our capacities, our knowledge on the environment in the transmission of the disease. We also need to use specific instruments to measure, for instance, the toxic vapors, toxic chemicals, and we need other instruments that are going to be used to measure this risk and to be able to take the necessary control measures. When we do the risk assessment for human beings, we need to assess if there is a sick person. We need to know, we need to study the hazard. We need to see if there is a dose response assessment and who are at risk, who are the professionals who are working, the patients at risk. And this risk is characterized, and we need to take these measures of control. For instance, when we use tuberculosis as an example, we have the risk, the patients that have tuberculosis, we know that the most exposed person is to a person with tuberculosis. And also, it also depends on the fact that the person is or not treated. The risk will be greater or lower. We also are going to consider the environment where the patient is. If the patient is in a risk with a controlled climatization, all those factors are going to be added. We are going to have the identification of the risk, and we are going to apply the control measures. This is a process that was carried out for all the hazards that can affect the respiratory systems of our professionals and patients. Another important aspect I would like to highlight here is that in general, we are going to focus our actions on the use of PPP. When we see this pyramid control, in this case, the pyramid of respiratory risk, we are going to see that the least affected if the PPP. I am not saying we should not use it. We need to use it. We need to implement the use of this PPP, personal protection equipment, but this has to be also complemented with other measures as implementing engineering controls and also administrative controls. This is just an example. For chemical risk, we can eliminate or we can replace the chemical material that is causing the risk, or we can replace the chemical with another one which will be less hazardous for the health. The engineering controls, for instance, ventilation systems, chemical protection hoods to guarantee a lower concentration of the chemical in the air, administrative controls to have a job rotation, to have less exposure to those chemicals. And also we have the use of PPE, personal protection equipment, that is going to complement this protection for respiratory protection, gloves, eye protection, protection against gases, protection against chemicals, or other specific protection measures. When we think about the biological risk, we need to see how we are going to eliminate or repress the risk. We need to make sure that all our professionals are vaccinated. We also need engineering controls. Again, here we are going to have the measures, including isolated rooms, biological cabins, the mechanically extracted air system. We also have as administrative controls, hand hygiene, and implementation and follow-up of these practices, but especially the standard operation procedures for the patient. And in terms of PPE, we have what we already know: respiratory protection equipment, gloves, the eye protection to reduce the exposure of the health professional to the risk. But here, the message is, once I know the risk, I have to implement a set of measures to reduce the risk under which the patient is exposed, the patient or the health professional or the sick patient. Once we develop a respiratory protection program, this program, as any other program that is developed in the hospital, these need to be planned, these need to be written, these need to be assessed. The first step for this respiratory protection program is we need to make sure that we have people who are going to be assigned to different responsibilities. We are going to have a risk assessment. I already mentioned we are going to select the ventilators for every type of risk. We are going to describe the procedures, how we are going to implement the program, standard operating procedures. We are going to have a medical examination of health workers to assess their possibilities to use these masks, these PPEs we are going to train, we are going to have a fit testing, we are going to have a maintenance program and the program evaluation. Usually, and for a long time, we were focusing all this program in the fit testing and also in the availability of PPE. And here again, we need to have respiratory protection program. This goes beyond fit testing and also beyond the use of masks, 95 masks. And all this is described in the PAHO guidelines that were issued recently. We need to define responsibilities. And this is important because as you see in the program, there are many components. We need many experts, we need to have people who are going to be able to measure the risk, train the workers, the health professionals, and that's why this group needs to be competent in terms of respiratory protection program. And we need many professionals with the responsibilities that are already defined. After assessing the risk, I already mentioned this. Every risk is different. We need to know the risk. And there are also many instruments. This is an OSHA guidelines to assess the risk and what are the risks that need to be assessed within the program. We also need to assess the chemical hazards. And maybe you are wondering, where are we going to get all this information with all the chemicals that are being used and how we are going to identify the risk? And the answer is very close to us. For all the components, they need to have this safety data sheet, and this material is going to give you the content of the chemical and also the risk to human health, and you can also define the measures you need to implement to reduce those risks. And here I am showing some examples of this safety data sheet, and this is also going to recommend the type of respiratory mask that should be implemented according to the chemicals in the hospital that are being used in the hospital. Here we have important terms, for instance, the maximum allowable limits to measure the limits in the health services. Sometimes we need equipment, as we already mentioned at the beginning. It is important to know the limits. It is important to minimize the risk in relation to the chemical agents. I think that the best example we have in the health services of badly measured risk is the glutaraldehyde example. Many hospitals use the glutaraldehyde for the disinfection of medical equipment, but this glutaraldehyde is not usually assessed, and our health professionals or workers rarely use or wear the necessary PPE to be able to handle this glutaraldehyde or a room with adequate ventilation to use it safely. When we talk about the biological risks, we need to know what's the type of measures that we need to implement, because not all of them are transmitted in the same manner. You already know about the droplets that travel to a certain distance to the source or to the place where we have our sick patients, or the airborne diseases that can travel further distances. We also have scientific evidence to prevent the transmission of these infectious particle for transmission, airborne diseases, or when they are transmitted by droplets. When it is transmitted by droplets, we need to know the recommendations in terms of the use of respiratory protection to implement the use of efficient devices, respiratory protection devices. And here we have a second part that was already developed, the fit testing. We need to know the respiratory protection devices. Although we have learned about the respiratory protection devices during the pandemic, there are still many failures. The use of these respiratory devices. So it is important to know how we are going to choose the respiratory device. It also has use different sizes, and the respiratory device should be tested before it is being used. Besides the capacity of transmission, it is already included in the respiratory device. It also has lifespans. That's why we need to have other control, other prevention, protection measures. And this is something we can measure, we can know through the information that we have.
To make a medical review and make sure that you know how to use these respirators, because it really helps, and it's very important for these people to undergo assessment. Besides this, people use this in stressful situations, physical or psychological. There are several instruments to this effect. This one shows the parameters that need to be assessed. And so when we train these workers and assess the risks, we need to move on to training the staff and to afford them respiratory protection. We know that the workers themselves, because they do not understand the occupational risks they are facing, they do not use the respirator. So people need to undergo training and need to know how to use the respirator as it should be used. Using the respirator is not only putting it on, you need to know how to use it accurately. These people need to undergo training every year. The tests for adjustments may be the best known aspect of this training, need to be done using several different models and types of respirators. Several countries have already implemented this, and once the respirator, which shows the best fit for a person's face, that person needs to have that exact type of respirator available for them for their professional needs. If a person uses respirator A size M, that very respirator needs to be available where that person will be developing their professional activities. This training also involves how you stock, how you maintain, how you repair, or how you discard respirators. This all is part of the training that is given, all part of the program. And lastly, there's a very important aspect that says that all of these actions need to be described and need to be able to be evaluated. We know that in health services, all our programs and all our proceedings must be written down and described in detail. So, when you begin to implement a program, it is very important that program needs to be written down from the very beginning. And that has an impact on program assessment and also on how we will implement the measures to improve this protection program. I know I've gone a bit over time, but I'd like to thank you all, and I will be very attentive to any questions you might wish to make.
Thank you very much, Valeska. Excellent presentation, very complete. And this leads into the next presentation that we have. And please, colleagues, if you have questions, put them in the chat or save them for the discussion that we will have later. So the next presentation, as you saw in the agenda, is Costa Rica's experience in implementing this program. So we go with Carol Andrea Brenes, that we already introduced. Go ahead, Carol. A very good morning, everyone. Please let me know if you can see my screen. Are you able to see it? Yes, perfectly. Thank you. Perfect. Yes, good morning, everyone. As was mentioned before, we are going to tell you a little bit about the experiences that we've had in implementing the respiratory protection program in the Costa Rican Caja of Social Insurance. Some general aspects of the institution. This is a state institution that has national level coverage, and as employer, you are in charge of more than 63,000 people. Go ahead, Carol. So at a country level, this image shows you the details of the distribution and networks, healthcare networks that we have. And to summarize, we have 29 hospitals and about 525 health centers. We call them SEBAIs. As you can see, we have national coverage, and it is governed by the state apparatus. Go ahead, Carol. So now talking about the implementation of the program in this timeline, we can see how in 2023, at the beginning of the year, we had first contact with PAHO and the institution. And for January and February, we adapted the donation processes and the process to receive the kits. By May, we have the first training of the first group of people. These were program administrators, and this is done by PAHO. June that year, we have a second training, and this is now led by the institution itself, specifically the colleagues of occupational health. Once we've established everything and the kits are at the hospitals in the areas that we're going to carry out the pilots in August of that year, 2023, we have dissemination and we present this to the network, the occupational health network. We disseminate the respiratory protection manual that establishes all the steps, and that also establishes or produces some standardization for the results. So in August of 2023, we establish some parameters and standardization where, as the slide says, we establish that the deliverables are 4 times a year. And by September, there's a training in the program, specifically the medical part, and this was coordinated by the colleagues of occupational health. We included PAHO personnel, and the target audience in this case were the uh, doctors that should get to know not just about the program, but their participation on the medical side. By 2024, at the beginning of that year, we again contact PAHO and we carry out the outbreaks workshop with the participation not just of occupational health professionals, but we also connect to epidemiology. So basically, since the beginning, what we do is we have a robust institution and we create several implementation strategies. So the first thing we have to define is who. And so we defined that this was going to be in specialized and national hospitals. This is 8 hospitals and 8 regional or peripheral hospitals. This is so that the program wouldn't just be centralized. And why hospitals? Because this is where we have the greatest focus of professionals that are dedicated to assistance. And there's greater complexity in the processes, so this was to be able to visualize risk in a more detailed manner. We also did this in a health area at a primary care level, and it may not have the complex processes or processes that imply as much risk as a hospital, but still they do have their own processes that merit the use of personal protection equipment. So we wanted to address that area so that we could learn about those characteristics. We also included one institutional maintenance unit, given that we didn't just want to provide we didn't just want to remain with the care for patients, we also wanted to address some of the more internal processes. The other strategies when we have dissemination or when we produce a manual is establishing dates, as we said before. We did this formally. This was a formal communication of deliverables so that we could have constant monitoring of the process. We also tried to standardize by using a tool, a standardization of outcomes. Then we matured and we realized that we had to update the tool. So for this year, at the beginning, we updated the tool so that we could have more details about the results that we're going to see in a minute. And likewise, we established follow-up on the the deliverables and sometimes the non-deliverables because of the circumstances of the healthcare center. But to monitor the program or to learn about situations that have run out of control that could impede advances. In general terms, here we have the outcomes that go from 2023 to 2025, where we can see in the first graph, we can see the percentage, the share of adjustment tests. And this is the population that belongs to the program. So 47% has had a fit test, and 53% are still pending. As I was saying at the beginning, the tool was produced and it had the intention of measuring who had the but now with the second version, those people that have the test, those who have a positive fit test, but with the type of PPE. So what I mean is that as a government, we do centralized procurement. So what reaches the services and the officials is a standard model. But the idea was to measure who, with the standard model, would pass the fit test and who wouldn't, so that we could determine whether we had a 100% coverage with that model, with that standard model. And what we were able to measure, what we already knew, and that is that there's always going to be people that will need some other type of personal protection equipment in sense of, or meaning different size. So there in the second graph here, what we have is thank you, Carol. What we have in that second graph is where 82% of the people that took the test passed the test with a positive fit test. With that standard respirator, the respirator provided by the central level, and 18% had to pass that test, but they had to change the size. They had to get smaller sizes in general to be able to have that positive fit test. So here we realize that we have a need to change the model and not just implement one single size. The third one gives us the percentage share of medical evaluation. So 32% of the current total number of people, officials in the program, have that medical evaluation, and 68% are still pending. And the last one is the number of people that were trained. This is a little more even. 41% have been trained and pending 59%. Now, I should clear up the fact that right now we have the results because within that standardization, we ask that when a facility, a service that belongs to the process, finishes its implementation, the administrator of that program should look for another occupational group of interest. This means that the results do not show the total outcomes. But what we do have is that we have several hospitals where there are services or groups that have been completely mapped with all their fit tests, with all their medical evaluations, with all personnel that has been trained. So as we ask for results year after years, and then we're incorporating new personnel or new services into the program, then we will always, well, we have that growth, so the numbers are always going to show pending. But in general, if we do have units where the program closed successfully in several of the services or occupational groups. So in the program components, okay, so in the key program components, we have the institutional interest program. That is, we have all of the managerial support, and this cascades down to all of the units that are part of it. The idea is that the whole institution will belong to the program. And we also have technical governing leadership. This is because the program is born and comes from the occupational health area, which is the uh, institution that is charged of occupational health and safety. And therefore, we're trying to harmonize and instrumentalize the program, creating document standardization, following up, and providing technical support, and of course, monitoring at an institutional level. We also have training, as I mentioned, the administration. So the training is, as we saw, the training is coming for the fit tests and the different parts of the programs. Produces a hierarchy through the program administrators and support through regional supervisors, and we of course involve the physicians that are providing care to the workers. And then we have the risk management process, where we incorporate, the idea is to incorporate, to embed the program in the occupational health risks management. And therefore, we are working on including this within a system or an IT tool that we call the institutional system for occupational health, where we can characterize the risk better and where we can provide traceability through this tool. So to continue, in this part, we wanted to bring the key points from the beginning, and we have had the support of other colleagues from occupational health, the doctors that are in charge of surveilling workers, for example, and they have collaborated in training the physicians that are providing the care for the workers. And we've also had the help of other workers that work on institutional development. This is a system that is in charge of digitalization. So we have had, well, we're the two who began the program, but we have had the support and collaboration of our office so that they would accompany us in other processes that are still part of this program. So the benefits at an institutional level have been mainly at a central level. We now have a practical, technical, and documentary structure of this preventive program. In terms of occupational health, it's difficult to establish preventive programs because many times, given the processes and because we are, I would call them square institutions, we are reactive, and therefore this is a preventive program that includes risk management as we saw it, because indeed the colleagues that are at local levels should do that risk evaluation, and we can see that these services are included in the program because they do identification and evaluation and surveillance, and we incorporate that medical control that workers have, in this case, personnel that is at risk, and we include medical evaluation with the forms that are established by the regulation, and indeed we adapt this to our country, and it's also complemented in training, and this is a continuous improvement cycle. It is also, we also have the knowledge of control measures of PPE through the delivery of results and the generation of initial actions where there is when we have gaps in knowledge, because indeed, at the pandemic, we were the entity in charge of evaluating the respirators that were be delivered in the services or attention units. So for us, the respirator should be certified. It should comply with all the regulations and everything else. But as I mentioned, we can have the best respirator, but it doesn't fit everyone. So if it's 63,000 workers, it's very difficult to get the same respirator. So through the program, we have seen that it is so. And the respirator doesn't fit everyone, even though this is a certified quality respirator. So this allowed us to go to the technical instances to ask for the purchasing of respirators in different sites, and that they could manage this. Because as my colleague said, given that we are a public institution, procurement is generally centralized, so we buy one or two types of respirators. But what happens to the people that indeed do not have a good fit? So this can be, in this case, we have a little more than 1,000 people in the program, and out of the 1,000 people, at the time that we made the request of opening the codes, there were 50 people that didn't have a good fit for the respirators. So then you say it's 50, it's very few, but indeed, those 50 people cannot be exposed to using personal protection equipment that is inadequate for them. So we went to the law because the law says that the physician has to provide it with the adequate equipment. And of course, with more real data, we were able to have that green light about the opening of the codes. And the codes are usually having smaller sizes. We buy standardized sizes. So now we requested small and extra small sizes for the respirators. And so we were able to monitor that percentile, the standard ones, and who needs a smaller respirator at a local level. The benefits have been the implementation of this preventive program for a specific risk, and this is done through identification and evaluation. We also have objective and certain and true information about the efficiency of the use of respirators and the convenience of using it according to the medical assessment. This is, of course, connected to the fit tests and, of course, having the SKUs or the codes. So now they have the codes that they need to buy the different sizes of respirators, and they don't have to depend on centralized procurement. So there are individuals that can go out to buy their smaller respirators as long as they have, because the program administrator is not buying the respirators. So the person in charge of procurement can buy the smaller respirators as long as they have an occupational health justification. So we have the technical justification that will allow us to, that the local level can use to buy the respirators. So where are we headed now? We're going to show you a video, but to give you some context, we as occupational health see that in the institutional occupational health system, we have been adapting or growing this program. So everything that is interesting to us, such as having real data that is up to date, well, we've involved this in the system. So right now, the system, in terms of risk assessment or risk management, we have a part that says that that identifies whether the risk that is being identified is related to a respirator. So we can now create a filter for every respiratory risk and we can see whether this risk is being included in the program or not. And please let me know if you can hear the video. It continuous improvement through technology and digitalization. I'm going to go back because I think it started in the wrong spot. Coming soon, a respiratory protection module in the institutional system for occupational health. This is a IT system developed to respond to the needs of occupational health to produce a positive impact and well-being in occupational health workers. Continuous improvement through technology and digitalization. Functionalities, registering fit tests, medically authorized results, statistics and history, and trainings. Registering fit tests. Medical authorization of results. Statistics of the results, integrating a risk management module. Process optimization and decision making. A respiratory protection program supported by innovation with the purpose of protecting the safety and health of people working in occupational health. Occupational health area, the labor well-being division.
Okay, so we have the lists of the units that currently are part of that, and the teammates are the local administrators. They have regional supervisors that actually provide the units that are in charge of us for implementation and development. And that would be our introduction or experience. If there's any doubt, please share that with us. Thank you. Thank you, Carol, Edward. This is an excellent presentation because you are showing this program not as an isolated program, but since it's anchored to this program, it's an idea of success. Thank you for being with us in this seminar. We are in the middle of our agenda, and I would ask you to hear this video on the quality, which is critical for that. And we're going to have the QIA icon so we could respond. And in the end of the video, we're going to have a general debate. We're hoping to finish in the next 30 minutes. We're going to have a recording after that. I want to thank Jose Carlos Espino. He's supporting us. He couldn't be with us today because he's on a mission, but he is sending us a really important video. I believe that we're not getting any audio at the moment. We're gonna briefly discuss the quality of air when it comes to health facilities. So why is it important to have venting on health facilities? Well, the HVAC actually requires special attention for hospitals. Many outbreaks of any type of infections are related to a poor maintenance, particularly when it comes to nosocomial infections. The HVAC system in hospitals are quite complex. We are seeing the OR, an intensive care unit with modern laminar flow systems, but not all hospitals in the region have these systems. We could have natural venting systems like the one we're seeing here. And actually, we're seeing modern systems with particular filters up to the conventional systems of natural venting. In light of this problem, PAHO have identified a need with the member countries to establish guidance on indoor environment quality in healthcare facilities. In light of this, we established a guide that we're actually seeing in this screen for year 2023. And this guideline basically sums up 4 specific areas for everything related to air quality, particularly hospitals. And the areas include venting, thermal comfort, filtering, and pressurizing. These are the main areas that we should care for to guarantee a suitable air quality in our hospitals. And we're going to briefly discuss each one of them. Venting, it's important. And this is going to depend on the air conditioning system from the hospital. Venting actually consists on the amount of air that we're moving, particularly external air or air coming from the environment that is going to be introduced. And such venting is going to help us control the pollutants that actually are generating in the hospital. If we have a poor pollution or ventilation, the pollutants are going to be within the hospital. For example, we have anesthetic gases generated by disinfectants. So there is a large amount of contaminants that are going to be generating in hospitals that we should control. And for that matter, we're going to mainly use venting. So this is one of the main concepts that we should cover and that we should attend to, particularly when it comes to the air quality on the health systems. And also we have the assistance of this venting health, because it's going to help us address the airflow within critical areas. For example, we're talking about ORs in this case. Now, the parameter which is relevant, particularly in countries in the tropical region, is the humidity control and temperature control. Not only because we have thermal comfort, but also because we can control the microbial growth within our facilities. We can see that we're gonna have mold growth, particularly in Central America and the Caribbean, related to the high humidity. And this would be one of the things that we need to control with the venting systems within our hospitals. Another aspect that we're covering on the guidelines are the filtering systems. This is a parameter that we are including infections related to health care. The fourth and last parameter, but this does not mean that this is not important. We have control of differential pressure. And this would guarantee that the air moves towards clean areas, towards areas that are not as clean. So this pressure differential is gonna help us to have areas that have negative pressure, like for example, the infections room or the isolations room, and this is regularly managed by differential pressure. One of the main problems are the doors of the critical areas, as we can see here. The doors of an OR that maybe are not properly sealed cannot be suitably maintained. This guide is gonna help us, or help the countries, to secure a proper quality of air in their health facilities. And thank you for your attention. I would like to mention that through you could contact your local office. We started this on 2023, and we have covered more than 10 countries when it comes to technical support and training for the personnel. Sorry. And thank you for your attention. I am hoping to see you in the future. Thank you. This is the request from Jose. This is a really short video. We understand that sometimes it's difficult to follow videos, particularly if you're not present. And he has been quite clear with the key messages, and I think we can have a regional support in this case, and I'm sure that you could set your questions, and we are going to do a follow-up on this. Now, we are going to start with the next presentation with the lessons learned and implementation. So, Milena, go ahead. Yes. So, Georgette, maybe you could help me for sharing this presentation. Thank you. So we are sharing the presentation. I would like to mention that what you guys shown in Costa Rica, it's a clear sample or example of the processes that we have when it comes to the challenges. So we're going to talk about the manual of respiratory protection that we have in this version. And we have this in Spanish, Portuguese, and English, and the implementation process and the challenges. We're going to be discussing about that in a second. So as you can see, this was published in year 2017, and actually we have had good responses in light of the pandemic, and we have seen lots of opportunities for tackling this transmission by air, and there was a need of knowledge in the face of those risks. So that's why we have a course that we were introducing in English and in Spanish. It started on January 2024, and up to this date, we have had a total of 55,000 people that were enrolled and certified. Certified, we have 37 people from different countries. This is a course in Spanish and English, and it introduced a model of respiratory protection. We have technical support, all the information, scientific evidence that we have had in this course. And I think that this course has contributed in strengthening the capabilities when it comes to managing these risks. As you can see, there are type of professionals, different types of professionals that have been enrolled in these courses. So as I was mentioning, the respiratory protection manual, we introduced the version from 2023, and this document has been a technical guide that has supported strengthening knowledge, particularly when it comes to the risks. So what we have been looking with this type of guides is disseminating the information required. What are the tools that we should have nationally and institutionally? So what we're looking for is that institutions or the countries work with the healthcare workers, and by identifying this, we could start mitigating risks. We know that we have countries like Aleja has mentioned, and as you can see, is not only about transmitting pathogens. For example, we could talk about different substances within the institutions, and actually these were not as clear on how to tackling the risks. Next, please. Likewise, this process was held. We have performed trainings, and we have 12 countries that have been trained, particularly on respiratory protection. We have performed 18 presence or face-to-face sessions, and we have applied this workshop in a regional and national level within the healthcare centers that I have mentioned. Next, please. Furthermore, we have the availability to see if we could have adjustment tests to complement the program for these countries. And we have 582 trained professionals. We have done some adjustments tests. We have not included the adjustments that countries were doing within their implementation of programs, but we also have consolidation of information with regards to what I just mentioned. So actually, what we were able to find and the systems that we should consider is that the implementation of the program, as you can see, it's a need that I believe the pandemic has shown, particularly the air transmission of pathogens. And as we could see, we have the presentation of Jose Espino of all of the risks. And we have many ways of tackling this. Institutions need to work on different lines. And sometimes we can work with the respirators, but these should be suitably performed for the workers. And as we can see, not all respirators are for all types of phases. So there's evidence that the adjustment tests would help us to have a greater protection for our workers. We have seen that by implementing this program, we need to articulate this with other lines and institutions, because sometimes we want to work from controls of infections and we require the health at work, the supports of directives or administrative areas for this to have growth, actually. And we have noticed that we need to acquire this type of programs as pre-pandemic. And we need to, of course, provide a follow-up and a backup so we could broaden the scenario. So to implement such programs, we need political will. And of course, this is going to be required to have a suitable implementation of such programs. So what we have seen is the identification of risks in workers, and there are multiple articles along those lines and management. For example, gas, vapors without any control, and that could actually impact the health of workers. Not only for generation of outbreaks, but also other type of typologies that could be chronic for the workers. We need to continue working on implementing this with the countries that we have been training. And of course, we're going to be working along that line. And I think that that would be my last slide on the summary of the progress that we have had with regards to the program. So for us, it was important to generate documents that could be of consultation for different processes. So thank you. And now you can go ahead. Thank you. I think the way that you mentioned, you have explained what has been the inclusion of everything in this program. We're going to continue implementing implementation in such countries. And for every country, we're going to continue collaborating. All the resources, as you can see, can be seen in the screen. And the idea is to anchor this with other activities, right? For example, occupational health, and other preparation, pandemic preparation topics. I would ask our colleagues from Costa Rica, Milena, to turn on their cameras in order to start the round of questions and answers we're going to start with a question which is for Costa Rica. This is in the chat box. I'm just going to read it. And it says, what's the impact that the application of the program has had on the incidence on respiratory diseases for the personnel? What indicators are you actually using to be able to determine this? So go ahead. Well, good morning once again. So the indicator with regards to control of diseases is actually leading us to that response, but the approach that we have had, it's important with the personnel of intra-hospital diseases, as well as other type of epidemiology, because in the end, we are just a link of the control of occupational diseases, particularly because we obey to the EPP, and we can guarantee that, but this involves engineering controls, quality of air, the management of outbreaks that we're actually not doing. These are our team of intra-hospital diseases. So institutionally, every time that we see an increase of such diseases, we must activate several controls. For example, we have occupational health. For example, all the actions that we should take regarding health, and also the management of outbreaks, looking for the cases as well. And this is highly related to our intra-hospital diseases team. And we wanted to have this approach because this process is not actually performed by us, but other areas. And this actually hasn't reached the occupational part. We have the medical side, vaccination. We have a guideline which is mandatory for the workers of our institution, the vaccination scheme that they should go through. And we have a way of verifying that we're actually complying with this, right? So we monitor, actually my teammate does this regarding occupational hazards and diseases, and we are able to control or identify everything which is actually within such covers of work risks. And this is actually our competence. This is what we should do, particularly in the pandemic. We were seeing that there were other hazards included here in Costa Rica. We were actually monitoring this, and I'm sure that we're going to see other type of cases, but that's the control that we're working with, particularly for occupational health. When we're having common diseases, I will have to mention that this is not within our scope, but this is work that effectively does not only correspond to epidemiology, but every time we have a symbiosis of these processes, I believe that that could be the way that we could effectively control it. For example, outbreaks, everything related to materialization of risks. So we don't have indicators as such for the diseases, but we are controlling occupational health, and effectively the personnel that will be exposed could be within the program, and he could receive all the required elements. I don't know if anybody would like to mention something else. Yes, basically I would like to mention what Carol is saying, which is part of where are we going, saying that the respiratory risks should be like a whole for the institution, and not only from an angle that could be security and health at work, basically. Yes, I don't know if somebody would like to say something, Milena Oleska. Yes? Well, I would like to thank everyone. I believe that this discussion of the indicators with our colleagues of Costa Rica have mentioned, and then there's indicators that I think that this is important, the implementation of the project. I think this has been excellent, everything that they have been doing, the synergies that they're looking for, and to protect the workers. But all those processes indicators include a lot of work, which is quite relevant, and I'm sure that in another or new opportunities are going to be able to share the indicators. And you have shown us things that could seem simple, but on the day to work, could be lots of work. Like, for example, how much percentage is not actually working on what we're actually procuring. So I want to take the advantage to congratulate Costa Rica on the implementation of the project. Thank you. Thank you.
So we have a question from Nuriz de Castro about excellent topics for respiratory protection, mouth covers, and other protection devices, and things that are not usually mentioned, such as sizes of respirators and fit tests. So that's a comment. I do not see any other questions. I don't see any other comments. Colleagues, would you like to add something before we close? This is for the panelists. Yes, I wanted to mention about the indicator that you were saying. Yes, I agree that this is a process that is starting. I think this is the next phase of seeing the impact. I think we understand, and this is one of the things that we were, sorry. Yes, one of the things that we were able to see during the pandemic, as we were saying, was something critical for many countries, and that was the uh, respiratory protection. So I would say there's a lot of work to continue doing, and we invite the countries to be motivated. This experience from Costa Rica shows us that there are a lot of things that we can improve and work on. And it's not impossible, it's within reach, and that this will contribute to provide safety to our health workers and patients. So that's it. Thank you. Thank you very much. Thank you for the presentations. Thank you, Milena. I will allow the colleagues of Costa Rica. Would you like to give us a final message for the countries? Your lessons or some recommendations, something that can be useful for colleagues that are implementing or are about to implement this program. Well, on my part, it has been very detailed work, and we have had to convince people because we are the ones who coordinate, but those who work, those who execute are other colleagues. So we have had to motivate the local levels, because one of our main limitations is the lack of resources. They already have many processes, and including one more can be difficult, but if we did establish that we're going to work little by little. We were going to start with 3 occupational groups, and then after those 3 we would go to a next phase and we would add these groups, because if we go to a whole hospital, national hospital from the beginning, a hospital that has about 6,000 or 7,000 workers, then evidently it will be very difficult. So we, since the beginning, we said, okay, we're gonna take the first priority groups for you. Maybe this could be pathology, infectology, pneumology. And they have worked little by little, and we have been feeding the program because sometimes at the beginning you want to do everything, but you can't. So we have accompanied them, and we have also, well, if there's a unit that has any problems in implementing it, we want them to let us know to see how we can support or maybe provide them some more time. There's a hospital that wasn't able to do it completely because they were really building a new wing, so we understood the situation, and the open communication has been a facilitator, open communication with the local levels to see what their limitations and obstacles are. So we can see how us or our regional supervisors can support or provide extensions and things like that. It has been a program that has been promoted but not imposed. Like you have to do it by this date and you have to achieve 100%. So what we do is we establish the deliverables and we work little by little. We ask them to implement it according to the material and human resources that they have. We do insist that they do involve other key stakeholders in the hospitals. For example, the Inter-Hospital Infection Committee, the doctor that's in charge of occupational health, or whoever is in charge of training in a hospital. The hospitals have programs called continuous learning, and they're usually led by nurses. So we see which stakeholders will allow me to, well, which who will support me so that the program can advance in a constant manner, not quick but constant, because we want it to not drop. We want it to extend to other services and to other hospitals when the time comes, when we see that this has been matured or established in these units. And that's when we can go to other units and start training them. That's my advice. Several pieces of advice, Carol. Thank you very much. Edward, do you want to add something? Yes, lastly, I would say that aside from what Carol has said about follow-up and about analysis, I think that dissemination of the outcomes creates pressure in the sense that a worker with that knowledge becomes an ally. So this part is also important. And that's why the trainings are important, and especially make outcomes known, because when we have a system that knows about a gap, can understand and move towards resolving that. So I think that 18% that I showed for us, aside from other things, but for us, it's a great outcome of how we can make a system more flexible so that there can be other types of procurements for these different size respirators and not have just this one centralized vision of how to buy personal protection equipment. Thank you, and I'd like to join everyone with the congratulations. Thank you, Carol. Thank you, Edward, for presenting Costa Rica's experience. And I'd also like to thank Milena, Valeska, and Priscilla. And we will be closing this seminar. And of course, we would like to repeat our commitment in the regional team to continue implementing these programs. So I will not close without thanking the administrative personnel. Thank you, Georgette, and the interpretation team, and the infectious Management of Infectious Diseases team. Thank you. I'd like to thank the countries that connected, and we'll stay in touch. Have a good afternoon.